Josh, in this class of drugs, because infections are common in refractory patients with lymphoma, but also in patients receiving these therapies, do you do anything for prophylaxis?
Yeah, in the beginning, we did little or nothing for idelalisib prophylaxis. There was sort of a standard of care change for both CMV PCR monitoring, and I guess we should emphasize it's CMV PCR monitoring because we saw some people were doing serology monitoring, which we don't think would be very helpful, and PcP prophylaxis. PcP prophylaxis was built into the duvelisib studies, I think, pretty early on. I have to say, in my common practice now, we have a little bit of both. We have some patients with histories of opportunistic infection of different types, and they end up on PcP prophylaxis. And I have some patients who've already been on idelalisib for 4 years and never had any problem, and I did not switch them over. There was these infection concerns with some of the randomized idelalisib studies, but it wasn't really that people were getting mostly sick from PcP, PJP. It was mostly a random assortment of other things, even the standard community-acquired pneumonias, other infections. So it wasn't really clear to us that just PcP prophylaxing these patients would make the difference in that risk for infection. So I don't actually have an absolute standard of care. And I have to say the CMV PCR monitoring in our hands has not been very helpful. We have not caught a conversion that we then treated. So I would say still the majority of our idelalisib patients are the ones that have been on for a while, and most of them have not switched over to PcP prophylaxis. Duvelisib, maybe different guidelines, and then copanlisib, I don't think we have any strong guideline to push for PcP prophylaxis.
Yeah, the duvelisib experience was based on early on the idelalisib experience, and it was based on the phase 1 study with idelalisib, where we did, and very early on, there was an agreement with the investigators to put people on PcP prophylaxis. But all these studies are a little bit of a mixed bag because they had, I guess in my chronic lymphocytic leukemia patients, I don't care what I'm treating with, relapse refractory, I put everyone on PcP prophylaxis. So, I think it's a reasonable point that we don't know. It is a fairly inexpensive therapy, barring someone getting a rash, with mostly upside to do PcP prophylaxis. So, any other differences that people can between these three agents? Of course, they hit the different isoforms, but from a clinical use standpoint, Nathan, any one patient population that you might treat differently with, might select one therapy versus the other?
Yeah, I mean, there's the main let me back up a little bit. I think when we look at the side effect profiles, I think it's as you mentioned earlier, it's not clear. We really don't understand why patients are having different toxicity profiles. If you look at the amount of delta and gamma that's hit across these different isoforms, they are variable. Could it be the dosing? My only point of that is that even if you pick a patient population, I still think you should be monitoring these patients very carefully, regardless of the drug that you pick. But if I had a patient, for example, that I'm a little more worried about compliance, I might be using something that's IV, something even if it's copanlisib IV, then you're kind of giving that in the clinic. Patients that tend to maybe have a history of uncontrolled diabetes, I might be picking something like idelalisib first. But outside of that, I think that, again, they're fairly similar. If you look at the response rates and you look at the remission times of both drugs, they're almost identical, right? Both of them are going to control the median progression-free survival of both these drugs is about a year. And overall response rates around the 50-60% response rate. So one's oral, one's IV, a little bit different toxicity profiles, and you just have to kind of individualize it to the patient.
Yeah, I was just going to say that I think the driving force, at least in my practice, has been the copays and the insurance aspect. Because even though there is support to getting some of the oral agents, it runs out after a period of time. So the first year is great, and then they run out. So, these are currently, unfortunately, treatment until progression. So That's a real barrier.
I just realized copanolisib kind of sounds like copay because you're going to get it covered. I don't know if that was built into the naming system.
Well, I too was concerned about the diabetes part of copanolisib, but then at this ASCO, there's actually an abstract where they pulled out their diabetic patients on trial, and it actually made me a little more reassured that you could do it in a type 2 diabetic, and through their clinical trials. So.
But I think even on those they had some A1C limitations, so people with very badly controlled diabetes.
Right, you had to have certain blood sugar to get started and things like that. You had to follow the protocol, but at least it shows that that population could still be treated.
I think the concern with those patients is going to be more likely oncologists that are just getting to use that medicine, overreacting, treating patients with insulin, calling up their endocrinologist, and the insulin's going to last longer than the copanolisib. They're going to get hypoglycemic
That's
afterwards.
exactly
That's where the
right.
danger lives.
That's
Really, the
exactly
majority of
right.
patients, are all back exactly at baseline 24 hours, no matter how they got treated with fluids or occasionally insulin. Mostly we should be treating those people less in terms of covering those high sugars.
Right. I think that's actually a really good point for safety, is
Yeah,
not to give the
especially those older
insulin, not
patients.
to react to that hyperglycemia because you will overshoot. And you wonder if with our CHOP, we don't check sugar levels with our CHOP, but I'll bet they're all hyperglycemic too.
Yeah, they
So.
certainly could be.